So our next physician speaker is Dr. Oliver Sartor. He's the director of Transformational Prostate Research Center at East Jefferson Hospital. He's also an adjunct professor at Tulane University School of Medicine here in New Orleans. He was a co-principal investigator for what was called the VISION trial, which ultimately led to the approval of some of the first nuclear medicine therapy for prostate cancer. He's also been a mentor to me recently, as I was a patient member of the steering committee for PSMA-4 clinical trial. And I want to encourage industry that's here in the room to please reach out to other patients. It's a bit of a learning curve to start on a clinical trial as a member of a steering committee, but when you have patients or physicians that are investigators that are patient enough to educate us along the way, towards the end of the trial, it's fascinating because I think it's fun to actually make an input to these incredible researchers that get so focused on the research that sometimes they forget maybe how to translate that into patient speak, right? And it's been an incredible experience, and I wanted to say thank you to him publicly because for including me in that multi-year trial, and it's been an education. And I encourage any patients in the room, if you're offered that or you would like to do that, we can try to get you into some of the corporations that are doing the research that we went down to talk to today. And more clinical trials are involving patients on those steering committees. So with that, I'll turn over the dais to you.
First of all, how are you? Hello. We've known each other years, and you've done great advocacy work with me. And I don't, like Mike said, I don't know much to express how much I appreciate it. So.
That's very kind. I appreciate you, and I hope the patients do too.
Thank you. So I want to start with my story a little bit because I think it's important. It helps people connect and relate. So my late husband was diagnosed in the year 2000. He was only 58. I was only 45, and our son was only 9. His PSA was 7,096.0, and he had bone metastasis in bilateral pelvis, bilateral ribs, his entire spinal cord, causing spinal cord compression, and his skull. I know it's a lot, so it's okay if it's a little bit shocking. It's all right. He was very stubborn, as you probably figured that out already. I got involved very quickly, and before I knew it, especially because we had a 9-year-old boy, that will get a mother involved like that. Before I knew it, I was reading his medical records, and I used Google as a dictionary to look up those big words. Did you know that osseous just means bone? I don't know why they don't just say that, but that's okay. I found out. And I used those medical records to, process what was going on. Then I used it to develop better questions. Then I found that better questions got me better answers. And about 1.5 years into his care, this was way back in the year 2000, before we had most of the treatments we have now. But I found that 1.5 years into his care, I actually chose a treatment as an idea. I brought it in as an idea. My husband and I had been talking about it. And I'll never forget that I was right. And his PSA, when we got it down to the lowest point, was 0.022. It's a very long, complicated story, but he lived for 13 years. That's way beyond anything that anyone could have predicted. And any survival statistics you can quote, I would encourage patients and caregivers to not let a static quote of survival statistics stick with you, because most survival statistics, by the time they're published, they're outdated. There's things we cannot measure. We cannot measure what's going to be FDA approved next month, next year. We cannot measure the power of the person being involved in their care. But we know it's there, but it's hard to measure. We can't measure it as exactly as we can a PSA, et cetera. So I was doing shared decision-making before I even knew what it was, And so now I try to pay that forward to people and help them understand that you can do it, and some bullet points of how to do it. And so we're going to talk from that perspective today. One thing I want to share with everybody is that in our medical system today, we've all experienced the pressure and the strain on the doctors. I want to mention, because I didn't even know this till about a year ago, there is a physician shortage across almost every field in the United States. So, and you can Google physician burnout even. And I'm saying that because it helps patients to understand what's happening in the clinic and with our doctors. And maybe I would start my doctor's appointment now with a simple thank you, and then I would go from there. But these are real problems. If you understand the problems, you can be part of the solution, create the solution, and still work your appointment, which is what we did. So I wanted to give that, just lay that down. Dr. Sartor, any comments on any of that?
No, I enjoy good questions because it indicates you're thinking about the disease. And it's actually hard when I speak without a good feedback from the patient because they don't quite know where they are. And, patients come from all over the place. And I have janitors that I treat, and I have CEOs that I treat. And I have rich people, I have poor people. And everybody's concern's a little different. And if I don't hear about your concern, I'm never going to understand your concern. So being able to talk to your physician and ask questions is very helpful for you to get better care and to have your concerns addressed.
Thank you so much. Okay, so we're going to speak about nuclear medicine treatments, which is a follow-up to the talk about nuclear medicine imaging. So in prostate cancer, there's 2 treatments, nuclear medicine treatments, that are FDA approved in the United States for prostate cancer. Let me make sure my clicker works. Let's see. There we go. So in an effort to do plain language, I always use both brand name and generic name. Do you mind if I ask you, as a physician, sometimes patients get confused because physicians and researchers speak in generic terms and we read in brand name. So why do physicians do that?
Oh, I think we're kind of trained to think about the chemical name, like radium-223, I refer to as radium-223 more so than Xofigo. I mean, Xofigo doesn't resonate with me very much, but radium-223, I know what that is.
Right. And is it a point also of not being seen as being branded, but just speaking to the chemical in case, let's say that one case scenario would be another company might pick up the same chemical. Something like that.
I mean, it could be. I mean, right now we have Pluvicto for PSMA 617, lutetium 177. That's a bit of a mouthful. So, Pluvicto probably does have a pretty fair amount of use today because there's no competition for PSMA lutetium. It could face competition. I mean, there's a company called Curium that's running a trial called Eclipse, and that could be PSMA INT lutetium 177. We don't have that on yet. So, in part, we speak out of convenience and a little bit of fluidity, but in general, I do kind of prefer the chemical name, assuming that it's doable.
Yes, okay. Well, I hope that explains for people because we get confused. So we'll use both names to help with any confusion. So in reference to Xofigo radium-223, if I'm a patient or caregiver and I'm trying to decide on Xofigo radium-223, and we had talked about this a little, in simple terms, this treatment will get paid for by Medicare if you're what we call on label, which means the label, when a treatment gets approved, it gets FDA approved, then it gets FDA labeled. And that label tells you which patients basically insurance will pay for. So I laid out as best as I could what would be the patient that Medicare would pay for. So is this accurate? On hormone therapy or testosterone suppressed, PSA rising, or more cancer on imaging, which is called metastatic castrate-resistant prostate cancer, which is another mouthful. We have a lot of mouthfuls. Bone metastasis specifically, no known soft tissue metastasis.
Not quite accurate, but let's go ahead and throw it.
Help me out.
I can kind of comment. So,
Yeah.
The original phase 3 trial, so the label is based on the trials that are run. and what we call the inclusion and exclusion criteria, who gets onto the trial, will determine the label when the FDA approves it, if they do. And this was designed for metastatic castrate-resistant prostate cancer patients with bone-dominant disease. It didn't have to be bone-exclusive disease, but we didn't want people with visceral metastasis because radium only goes to bone, so visceral would be something like lung or liver. So radium doesn't go to lung, doesn't go to liver, so why would you use radium to treat someone with lung or liver disease? The symptomatic was a little bit weird, and symptomatic caused a lot of trouble in the label because did that mean fatigue? Did it mean pain? Did it mean you're symptomatic in your head because you're thinking about it all the time? I mean, it's a very nebulous term. And that has kind of been dispensed with when it comes to radium. The symptomatic part is difficult to interpret, and so I kind of dispense with it.
Okay.
One thing, and this just for clarification and maybe interest, and when thinking about radium, because it's a bone-dominant osteoblastic disease, only works for osteoblastic. It doesn't work for osteolytic. She's probably looking at me and say, why are you using that big
No, I got it.
osteo word? I guess that's the terminology we use. Lytic means destructive, blastic means forming, and the typical prostate cancer is blastic, meaning bone forming. And radium is taken up into the bone forming elements, but not the bone destructive elements. So we're looking for that bone dominant patient, castrate resistant, metastatic, and that becomes a reasonable candidate for radium so long as their soft tissue disease is not too predominant.
So visceral means, in simple terms, soft tissue metastasis?
No. Viscera refers to organ.
Okay.
So, you can have lymph nodes, which are not viscera.
Got it.
Viscera would be like lung and liver.
Bladder?
Bladder, it's kind of
Rare,
a weird one.
really
Well, it's typically local invasive into the bladder, but
Okay.
it kind of depends on how bad it is.
Okay. And I want to reference this. I find that liver and lung get mentioned, liver metastasis and lung metastasis get mentioned together a lot, and they both start with an L, and sometimes we think they're similar, but,
They're not.
thank you.
Yeah, they're not.
Elaborate, please.
Yeah, liver's bad, lung's not so bad. And one of the things interesting about prostate cancer, you can look at the location of the metastatic disease and have some idea about the prognosis. I call it the hierarchy of badness. Lymph nodes are pretty good, relatively speaking. Bone is not so good, and liver's bad. And so in that hierarchy of badness, I'm kind of calculating like where the patient's going to end up. And truth is, lungs are more like lymph nodes than they are liver.
Thank you for that.
Even though they're both viscera.
I think that's really important information.
Yeah.
Really quick on osteoblastic, most prostate cancer metastasis, this is something you probably see on a regular bone scan. You could distinguish between the thing that looks like a bump in the bone as opposed to a dent in the bone. Is that?
Yeah,
that
pretty easy. On a bone scan, you're basically imaging what we call the hydroxyapatite, fancy chemical name for the bone stroma that forms from the blastic lesion. Bone scan hot, that means it's blastic. Bone scan negative, it's not.
Radium would be for blastic metastasis.
Radium is for blastic.
Thank you very much. Okay, next one, I just think it's helpful for patients to understand that there's only two different types of physicians that administer Xofigo or any nuclear medicine treatment. Nuclear medicine physician oncologist like Dr. Al Miguel. Did I say your name right? Yes? Okay. And then a radiation oncologist. I'm not even sure people really understand that. Whereas your medical oncologist or your urologist may refer out to one of the two. Is that how you would say it?
Yeah, there's something called an authorized user, and the ability to administer a radioactive material is restricted to those who have special training. So somebody like Francis in nuclear medicine is an authorized user. I am not. I don't have special training.
Because you're a medical oncologist.
I'm a medical oncologist.
Right.
And urologist is not. So your radiation doc, radiation oncologist, or nuclear medicine doc are the typical authorized users.
Okay, next slide. Question, I think patients do wonder about this. If I'm on one treatment, here we're talking about Xofigo, radium-223, are there situations where I might consider taking another treatment along with it? Not everything is contraindicated, but not everything clearly has been studied or goes together. So we talked about, so there's a trial, let's go to the second bullet point first. Zytiga or abiraterone did not do well in a trial. It would be contraindicated? What would be the right word?
You know, I have maybe a different perspective on it.
Thank you.
The Area 223 trial
Yes.
was an abiraterone plus or minus radium trial.
Yes.
That did not do well. Tons and tons of fractures, and the patient didn't do very well. It is not indicated to give those two together. Interestingly, however, the defect in that trial, which was a defect that was never corrected, is the bone health agents
Thank
were
you.
not co-administered.
Yes.
So bone health agents could be things like denosumab, things like Xgeva.
Right on the
because-
bottom.
Yeah,
Yep.
there you go, denosumab, Xgeva.
Yep.
Or zoledronic acid, Zometa, and those are the brand names and the generic names. So zoledronic acid, denosumab, same thing as Xgeva, Zometa, okay? So when you give the bone health agents in combination with radium and abiraterone, the truth is you dramatically decrease the fracture rate. Problem is, it was never done in a prospective trial that way, and so consequently, the abiraterone is not used. And if I draw a contradistinction to that, the Peace 3 trial looked with enzalutamide combo, very interesting.
First
and-
bullet point.
And
Yep.
not necessarily well known. So the Peace 3 trial started out disastrously. And the disaster was the fracture rate was through the roof with a combination of enzalutamide and radium. And I happen to be on what we call the data monitoring committee. Big trials have independent data monitoring committees looking over it, try to look out for the safety of the patient. And we noted this fracture rate very, very early. And the data monitoring committee put out a strongly worded letter saying, you must give bone health agents if this trial is going to continue. And if you're not on a bone health agent, your physician must justify why not. So the default is you do it, and if you don't do it, you tell us why. Because of that, and we have before and after,
Yeah.
the fracture rate dropped dramatically. And the enzalutamide radium combo trial is positive for overall survival. It's complicated. It's presented at ESMO 2024. ESMO, the European Society of Medical Oncology meeting, big meeting. There are two big meetings. ASCO, American Society of Clinical Oncology, ESMO, European Society of Medical Oncology. Presented at ESMO 2024 by Silke Gillison, great investigator out of Switzerland. And Silke presented it very conservatively. The statisticians had some questions about the trial, and they wanted to have more data. That data is actually now accumulated, and they haven't analyzed it yet. We'll look forward to a new analysis on Peace 3, never reported in the peer-reviewed literature, but it will be.
Okay.
And I think it'll likely get an FDA approval.
Very interesting. I think the bone protective agent, I think they call them BPAs, bone protective agents, so I try to use the same words. It helps patients.
But in fairness, some people call them bone health agents, some people bone protective agents. You know, so the nomenclature's not fixed.
Yep. But I think it's important that patients who are metastatic and on testosterone-suppressing drugs be asking their doctor, and this does get overlooked, I've seen it many times, for a DEXA scan, number one, which is easy, quick. Help me out.
No,
No?
not true. Because see, here's, and I'm not trying to be rude.
No,
I'm
you're
just
not
trying to
at
be
all.
corrective.
This is good.
No, because see, when you have bone metastatic disease, you got to be
Right.
very careful doing a DEXA scan.
Right.
Because the blastic lesions increase the bone density.
Yep, falsely.
So if no, not falsely. It's a real increase, but
Okay.
it's not measuring your natural bone.
Okay.
So there's a distinction between the metastatic lesion and the rest of the bone.
Thank you.
When you're running a DEXA scan on somebody with a metastatic lesion, you got to be very careful not to assess the bone where metastases are, because then you get fake. And I'm going to complicate it, but I'm going to simplify it.
Yeah.
There are two elements here. There's the bone that is not involved and the bone that is involved. For the bone that is not involved,
With metastasis.
with metastasis,
Right.
we worry about osteopenia, osteoporosis, fancy word meaning loss of the bone strength, which we can measure with the bone density. For that,
Right.
and then this is, again, a little bit confusing. We use the second version of denosumab, one called Prolia, and we use the second version of zoledronic acid and only give it once a year. So for osteopenia osteoporosis, we use one thing. For those at risk for pathologic fractures where there's bone metastasis, we use these two, which is denosumab at a different dose and zoledronic acid at a different dose. Now, to complicate things, but to be honest, the dosing is not well worked out. And there's a lot of interplay between giving too much and not enough, and we don't quite know.
So what should I ask my doctor? Okay, so if you don't have a they typically scan with a DEXA scan, the left hip and then the lumbar area, correct?
Some people do wrist as well, so but they're different standards.
That's on ultrasound, isn't it? Okay.
No,
all right.
no, they're DEXAs on the wrist, wrist and hip and lumbar.
So if you're scanning an area of bone that does not have a bone metastasis, it may be a valid imaging.
Absolutely.
Okay. And, but what I find is missing is that anybody measures anything, the doctor in the clinic, to be fair.
Yeah, but
And so the patient doesn't get the bone protective agent. This is the point I'm getting to. So
Yeah.
ask.
One more clarification.
Yes.
So the bone health agents for osteopenia osteoporosis are being driven by the DEXA scan or bone mineral density. But if you have bone metastatic disease, it's a different category.
Then you can order Xgeva.
Then you can potentially order
Without a
Xgeva
DEXA
or
scan.
zoledronic acid.
Thank you.
However, this
Yes.
is an important point. The actual dose intensity is debatable.
Okay.
The FDA approval came out once monthly, and it's not clear that that's really the right dose.
Understood.
Okay.
That gives patients a good thing to research, a good thing to ask their doctor about.
Absolutely.
But still, don't avoid the discussion about bone protective agents, even if your doctor hasn't brought it up.
Absolutely.
The risk of fracture is real.
And if you're on radium, then you ought to be on a bone health agent.
Okay,
Period.
thank
Because
you.
that means you have bone mets.
Right,
Yeah.
right, okay. So then I brought up both Nubeqa, darolutamide, and Erlita, apalutamide, just because they haven't been studied in conjunction with Xofigo, radium-223.
Yep.
But I just wanted to make the point and then lay it out there. Who knows if they'll study it one day? I don't know. You said the Peace 3
No.
trial, yeah, is,
Took 10 years to run.
yeah, got it, okay. I want to remember that we're talking about things in the United States, but people on YouTube could be listening from Canada. But it's not only live right now, but it's going to be on the internet, and we don't know who's going to watch this. So we're speaking a lot to USA data, but there may be other people in other situations. Okay. So if I was receiving Xofigo, radium-223, I'm convinced that side effects are something that often get overlooked in the clinic or understated. So focusing on them is a big part of my shared decision-making effort. So I know that hydration is recommended. I actually wrote an article about that. It's on the last slide. What are some of the things that you can do to help a patient understand side effects better and prevent them or treat them?
No, they just communicate. Radium is one of the few agents ever where the adverse events within the placebo group, it's actually a placebo controlled trial.
But it was placebo plus standard of care.
Correct.
Thank you.
But it was placebo or radium, so nobody
Right.
knew if they were getting radium or not.
Right.
That the adverse events were actually less in the radium arm than they were in the placebo arm.
Right.
So you had less side effects if you received radium. Now, side effects is a broad term because this is related to the disease as well as the drug. But the truth is, radium was very well tolerated.
Okay. I want to keep going because
Yeah,
I'll
I'm
talk
sorry.
too much and lose. No, it's me.
I
I'll
talk-
lose
No,
time.
I talk too much.
Thank you. By the way, if I'm learning as we go, that's exactly where I should be as an advocate. And as patients and caregivers, that's the place you want to be too. We're always learning. So, okay. So talking about self-care, family care, they'll go over this with you in the clinic, a technician or a nurse practitioner. But I do want to talk a little bit about getting your copies of your medical records, including your CBC, which has your hemoglobin, your hematocrit, white blood cells, platelets, Platelets can be difficult to recover, but there wasn't a big deal with radium, is that correct?
I think that maybe 10%.
Okay.
I forget the exact
Okay.
number. Wasn't too bad.
Blood counts weren't terrible, but still get your copies of your CBC
I
blood work?
I think it's good to follow along.
Yeah.
Yeah.
Follow along. Anything, PSA response is,
Low, very low. With radium, it's probably in the 10% range.
yeah, the direct PSA drop, for example,
Yeah.
was difficult to measure, find, it was inconsistent.
No, it just didn't, it doesn't drop PSA.
It doesn't drop
Yeah, it
PSA?
just doesn't drop PSA.
Nobody got PSA drop?
Less than 10%.
Less than 10%,
No, no,
okay.
no, it's a rare event.
Yeah.
And radium, we could have a long talk on the mechanism of action of radium.
That's okay.
It's a stromal-based therapy. It's a radionuclide that binds to the stroma, not the cancer cell. The Pluvicto, or PSMA 617 lutetium, binds directly to the cancer cell, and there you get the PSA drop.
Interesting, okay. Thank you, I'm going to move on. We're going to move now to Pluvicto, lutetium-177. It's a much longer name than that, sorry, I shortened it, because this is what most patients and advocates saw during the clinical trials early on, was lutetium-177. Deciding on lutetium, again, which patients does Medicare pay for? What's on label? It's similar to Xofigo, but different. On hormone therapy or orchiectomy, but testosterone suppressed. Advancing disease measured by PSA rising or more cancer on imaging. Fair? So far, so good. So that's called metastatic CRPC or metastatic castrate-resistant prostate cancer. We used to call it hormone refractory. So patients and caregivers, if you're searching on this and you find that, you're tapping into an older term we used to use for almost the same thing. What's different about this is you need to have a PSMA PET scan that was positive.
Yeah.
Correct?
So what you need is a biomarker for the activity, and the biomarker for radium is a bone scan. You have to have a positive bone scan to be considered for radium. And for the Pluvicto, you need a PSMA PET scan that's positive. So there's a distinction in the scanning, and here we're targeting PSMA. This sort of gets back to the theranostics that was raised earlier by Francis. So we've got to have a PSMA PET positive.
Thank you very much. Okay. This is the same as the Xofigo slide, which doctors give Pluvicto, lutetium-177. It's your nuclear medicine physician or oncologist and a radiation oncologist.
Mention one more thing about the indication.
Yes.
So we actually have a
Yes.
new indication that came out in March. And for the Pluvicto, initially, you had to have both chemotherapy with a taxane chemotherapy, such as docetaxel, and an ARPI, which is something like abiraterone and enzalutamide. In March, a new FDA approval came out in which you did not require prior chemotherapy.
Right.
So that's a new indication by the FDA.
And taxane is basically docetaxel or Taxotere. Those are the two names for the most part.
Yeah.
Although it could be,
It could also be cabazitaxel or Jevtona.
right, okay. And it's pre-treatment with it, but it's a non-issue now because the label changed. Okay, thank you. So I'm going to move on from that one. And by the way, there's a couple of references here regarding side effects. To consider talking to your nurse practitioner or your PA about your side effects. Doctors, as we mentioned, are busy, sometimes over busy. And nurses and PAs, this is my own personal take. I'd be curious to hear what Dr. Sartor, his view on this. They have a tendency to be able to spend more time, or they listen, I don't want to say better, but they just have a knack for it. And so if you have a side effect, we tend to think of our doctor all the time, but if they're too busy, let's use our other medical professionals in the places where they're strong. And this is one for nurse practitioners and PAs. So during Pluvicto, again, can I ask my doctor about taking other treatments? Do we know if you should stop Xtandi? Do we know if you should stop Zytiga? What do we know?
So actually, drawing on the Alsimca trial design, which is standard of care plus or minus, that same trial design was put in place for the Vision trial, which led to the first FDA approval. Standard of care plus,
Pluvicto.
yeah, for
Yep.
Pluvicto, standard of care plus or minus Pluvicto.
Right.
And so people were on the abiraterons and insulamides and bone strengthening agents and steroids and all that sort of stuff, exactly like they were in the radium. Now, the addition of something like abiraterone and enzalutamide is probably reasonable for those who are on the Pluvicto, but the only data that we have that's prospective looks at enzalutamide plus or minus lutetium from Lee's Emmett called the ENZA-P trial.
Okay.
And that trial showed that the combination of enzalutamide plus the lutetium was better than enzalutamide alone.
Okay.
So different way of looking at it.
Yep. Okay. So it's an area we don't know. Perhaps you could talk to your doctor?
Absolutely. Great,
Okay.
great question. Some
Thank you.
people I do treat with combination. Absolutely.
Okay. All right. So
And bone strengthening too.
so it's not contraindicated? It doesn't say anything on the label about stuff? Okay. What would be contraindicated is probably chemo along with Pluvicto? something
Yeah,
like
we
that,
don't,
yeah.
we don't know if that's safe or
Yeah,
not.
yeah. Thank you. Are SPECT scans important? We were just talking about that with Dr.
You know,
Alm
it's
as
a
well.
great question, and actually, I do kind of like a SPECT scan. The PET scan can serve the same utility, but then PET scan is a separate test and more expensive. So the SPECT scan is you inject the lutetium, and then you can image later to see the lutetium and where it goes. And you can see if the volume of the disease is going up or going down, is it getting better, getting worse. I kind of like the SPECT scans, but I'm not adamant about getting them.
Okay, so I can ask my doctor about it.
Good question.
Thank you. Better questions get you better answers, so
Yep.
that's my tagline somewhere. Okay, during Pluvicto, self-care, family care, again, keep copies of your CBC, ask for them. It's your blood work. Nobody goes home with your cancer except for you. So, what about PSA response with Pluvicto as opposed to Xofigo?
Yeah, it's context dependent. In the Vision trial, the PSA response rate was, I'm trying to remember exactly, I think it's 43%. In the PSMA-4 trial, which is in the pre-taxane setting, is about 57%. And, you know, the rough rule of thumb for Pluvicto, and I think Frank has also said it pretty, when it works, it really works. About a third of the patients have like phenomenal responses. About a third of the patients, it doesn't work very well, and about a third are in the middle.
Okay.
But about a third of the patients are just like, oh my God, can you believe that?
Right, and the PSMA-4 trial was the trial where they studied Pluvicto on patients who had not had chemotherapy, not had Taxotere, docetaxel, so earlier in the disease. And the data from that was as good as or better than
Better,
better.
yeah.
Better,
Now,
thank you.
survival is a little bit complicated, and I probably
Yeah.
don't want to go there, because we had a lot of crossover. The Vision did not have
Yeah.
a crossover.
Okay,
The earlier trial did, so, you know, like 57% of the patients who did not get the Pluvicto initially crossed over and did get it later. And I think the survival was screwed up, because, not screwed up, it was, it
Challenged.
mitigated the effect of evaluating the survival because of the crossover, because so many people received Pluvicto either way.
right. A crossover written into a clinical trial means that if you're on the arm that doesn't have the treatment and your disease advances, you're given the option to cross over into the group of the trial, not arm, people don't know what arm means, it's like this.
That's right.
The group of the trial,
Well-
where you can receive the treatment eventually.
Well, to state it another way, so everybody got randomized to Pluvicto, so 100% of those people got Pluvicto. The other arm was randomized to no Pluvicto, but the truth is 57% of those people still got Pluvicto.
Right,
So you're comparing 100% versus 57%,
got it.
and that's a little complicated.
And randomized just means that when you put people in the two different groups, it's random.
It
It's done
is.
randomly.
It is.
Thank you. That term's used a lot in clinical trials.
Yep.
During Pluvicto, again, can I do things to help prevent side effects? Do you tell your patients to hydrate?
Yeah, it's reasonable. I don't want anybody to be dehydrated, but hydration is reasonable, but it's not going to change that much. The dry mouth is probably the thing that's a little bit unique for the Pluvicto because you have salivary uptake.
Right.
And then we try to ameliorate those symptoms and things like xylitol and even chewing gum or candy. I mean, there's some things that we can do.
Right. And you said that using ice packs on your saliva glands to
Doesn't work.
prevent
Doesn't work.
has been shown to not work.
Shown not
Okay.
to work.
Okay. I think it's helpful to remember that the side effects do get worse as you go. They're cumulative for the most part.
You can often get fatigue. That can be problematic.
Do you ever have a patient ask you, patients are always weighing risk and benefit. Every treatment decision really should be made that way. If someone's got a great response, but they're really exhausted or having bad side effects, can they ask their doctor about stretching out the time between the next Pluvicto treatment, or?
Yes, and it's a little bit artistic now
Yeah.
because we don't really have the good data. You know, the good data was given at every 6 weeks, and alternatives to that schedule have not been explored.
Right.
Unless you have a phenomenal response. But I think there's always a lot of judgment that goes into the next treatment decision. And I'm not kind of an ex-cathedra guy where we say, okay, every 6 weeks we got to do it. That's my default, but it
Yeah.
doesn't mean we can't discuss it.
Yeah, and patients can ask.
Yeah.
Patients should be thinking about benefit, which is their response, side effects, which is, doctor doesn't know the side effects until you tell them. That they might know the response, they don't know the side effects. So ask, speak up. I have seen patients who stopped a treatment that they were responding to because the side effects got so bad, and no one worked to either prevent them or help them with the side effects. And that's a shame because their cancer was responding to the treatment.
You know, risk benefit is real, and we
Yeah.
have to evaluate not only the benefits of therapy, but the risk of therapy. And to your point, if the patient doesn't speak up, you know, how do I know if you're tired?
don't know.
You know, I mean, your fatigue, your dry mouth may be super bad, but if you don't tell me, I don't know.
Maybe affecting your appetite, which is important.
Absolutely.
Risk-benefit is exactly what's studied in the clinical trial and exactly how a treatment gets FDA approved. So if you're speaking to it in the appointment, you're speaking the right language. Here's a couple of articles. Full disclosure, I wrote the first two personally. And then a short article about risk of osteoporosis while in hormone therapy by another group, Dr. Mark Scholes out in California. How are we doing on time? Do we have any time for questions? We got a few minutes. Anybody have any questions? Thank you so much.
Thank you.
Anybody have questions? Is everybody tired? Come on, we need a little more coffee.
Again, Frank Leskis from Blue Earth Diagnostics. Dr. Sartor, you mentioned a little bit about the dose, or the time between doses and still being studied. What does the future look like for that algorithm? Are you basing it based on those that have responded, maybe extending that time or shortening the time for those that are not responders, or the variability in what will be a 6-dose regimen, an 8-dose regimen, a 4-dose? How are you thinking about that into the future?
For Pluvicto, you're.
For Pluvicto, yes.
Thank you.
Yeah, we're not thinking so much about stretching out the dose right now because we don't have a lot of data on that. I'm on Channel Louise Emmett from Sydney, Australia, who's been studying this probably more than anybody else. And I may have mentioned her name already. She's a fantastic investigator down in Australia. And she's been really studying pausing the dose among those people who have good responses. And I think it's 17-18% of her patients just got 2 doses, and then they paused and then be retreated when the PSA started to go up. And I think that's pretty reasonable for those people who have terrific responses. Do you need to get 6 in a row? And the answer is, you know, that's what the trial did, but it doesn't necessarily mean that's optimal. The other thing that Louise is doing is she's changing the way that some of the initial doses are administered, so crowding them together a little bit. And also it's being studied in England, so they're using the same dose of Pluvicto day 1, day 8, instead of day 1, day 43, which is 6 weeks. So they're like literally doubling up the dose. I did a trial with Scott Tagawa, great guy out of Cornell, and we gave 11.1 gigabecquerels on day 1 and day 15, so 22.2 gigabecquerels over 15 days. FDA approved is 7.4 every 6 weeks. So far, we haven't run into trouble, but how are people exploring it? We're looking at more intermittent dosing. We're looking at more front-loaded dosing. But right now, I'm happy to go intermittent, but in the trials, I need trials to be able to show that the more intensive dosing is safe.
Do we have any questions on YouTube? Sorry, go
right here.
Go ahead, yeah.
Yeah, Jean-Luc Vanderheden with the Oncidium Foundation. You mentioned one-third of the patient do fantastic, one-third so-so, and one-third don't do very well on Pluvicto.
it's kind of a rule of thirds.
Do we know what makes a fantastic response and what makes a terrible response?
Great question.
Great question. So I would like to add a simplified answer and tell you that what I'm about to say is not completely true. It's only partially true. So when we look at the scan, there are parameters on the scan, the PET scan, that can predict good response. What are those factors? Number one, imagine that the PSMA PET uptake has an SUV, standardized uptake value, extremely high, that it's 25. I look at your PET scan and everybody's got really bright disease. Let's imagine that that really bright disease is entirely within the lymph nodes. Remember my hierarchy of badness? This is the hierarchy of goodness. So when I see a patient with a super high SUV uptake in lymph node only disease, bingo, that patient's going to have a beautiful response. If I look at a patient who has a relatively low SUV, and I'll say SUV max of 6, and their disease is in the liver, guess what? They're not going to do very well. Imagine that I look at a patient and they have 159 bone lesions, and I look at another patient and they have 3. Guess which one is going to do better? So looking at what I call the SUV uptake, leading to the location of the disease, leading to the burden of disease, I have the capacity to make reasonable predictions. But you know what? I'm not always right. And there's some interesting factors that I don't understand that go into the equation as well. Great question. We're all learning, and we hope to get better at this.
So SUV is part of your PSMA PET scan report. This is the importance of reading your medical records, and it means standardized uptake value? Is that correct?
And higher is more uptake. And the thing that, is sometimes a little bit irritating, we don't always get that in the report. And it needs to be, as we evolve through the PET scans, we're looking, and I only gave you a partial answer because we need more data to create something called an SUV mean, which is the typical uptake. And ideally, we'd also understand the heterogeneity of that uptake. And then we also have to understand about discordant lesions. So, I could talk about this for a long time, but it's a great question, and it's one that I'm personally engaged in trying to answer better.
Any other questions?
Yeah, so we have 3 more questions, so 3 minutes each, so we'll try to keep each to 3.
It'll be okay.
Well, she's till
At 4:10.
4:10, so I'm talking 4:10. Okay, so Mike Philbin, question, hereditary cancer. So my understanding is what, 10% of metastatic prostate cancer is family-related?
Are you talking about BRCA2?
Yeah, well, I'm leading into that. So which is typically BRCA2 mutations. Is there any special considerations?
I'm going to correct you. It's not typically BRCA2. BRCA2 is only about 38%
Okay.
of the hereditary cancers, with things like PALB2, CHEK2, BRCA1, and other parameters that need to be measured.
Okay.
So BRCA2 is only one of the
Okay.
many genetic factors.
Right, but either way, for hereditary type cancers, whether it's which one it is there any differences for men with hereditary cancers in terms of how Pluvicto works, or?
Yeah, so within the trial, there was an exclusion for those who were known BRCA2 metastases or BRCA2 genetic alterations, because we have an FDA-approved PARP inhibitor for those, things like olaparib, talazoparib, or the PARP inhibitors. And the FDA felt, and I would agree, that if you have these known alterations that are sensitive to a PARP inhibitor, go get your PARP inhibitor. So we don't have a lot of data on this, and it's a little bit of a mixed bag. There's some people who seem to think it's a little better, some a little worse, but we don't have a lot of experience with the unadulterated BRCA2 population. There's a lot more that we need to learn about genetics, and I'm actually studying that. That's part of my research.
Okay. Did we have a YouTube question?
We
Mike?
do. Online question. Can you go into further detail about precautions caregivers of patients on Pluvicto should take? How dangerous is the radiation exposure to caregivers?
Can you give information on how caregivers should protect themselves and home care, and how dangerous is the,
Radiation exposure from Pluvicto to
Yeah,
caregivers.
It's not particularly dangerous, at least in my own way of thinking. You know, the way you manage the radiation risk is to keep distance, and it decays over time. There's a 7-day half-life. So during the first week, some distancing is probably appropriate, but, you know, probably having somebody sleep in a separate bed for a week is acceptable. And, you know, there are guidelines, some of these are by state, but social distancing, is it dangerous? I don't think so. At least, you know, we always prefer that less radiation is more better. You know, we don't want people to be unnecessarily exposed to radiation, but I think social distancing is probably the best thing. It's not a big risk.
I would like to ask a question about data regarding African American men and black men in the VISION trial, the PSMA-4 trial. Were we able to recruit a large amount? What do we know about their response? And one reason that's
Poor.
interesting.
It was poor recruitment in African Americans. Remember, it was a trial that involved not only North America, but also many other locations, and the African Americans were a very small percentage, not able to say much. One thing we did discover from our genetics is there's an alteration called CDK12 mutation. CDK12 mutations do not respond well to Pluvicto, and African Americans have a higher percentage of CDK12 mutation.
Interesting, thank you.
That actually was a little bit of my follow-up question on the high responder, low responder, if there was any genetic test or something in the blood
Great
that
question.
could be helpful as a predictor, and what would you do if you had that information?
Yeah, no, great question, and an area of very active study. So I can tell you for the response rate that something called the circulating tumor fraction of the circulating tumor DNA is quite important. And this came out of a beautiful study that just came out in Nature Medicine by Alex Wyatt and colleagues. We published this in Journal of Nuclear Medicine. We found 3 alterations that seemed to predict resistance. One of them was the CDK12 I just mentioned. Another was the CCNE1. It's also been associated with platinum resistance, and another called FGFR1. We're kind of at the infancy here, and the studies to date have not been definitive in my mind. The single best manuscript on this was just published by Alex Wyatt in Nature Medicine, and the degree of the circulating tumor DNA is an important parameter. Yeah.
We have about 5 minutes left. Is there maybe one more question? Look, Mike Crosby has a question.
Mike, I'm gonna follow up a little bit on his, because I think it's a very good question. This interplay between the genetics of the tumor and the scan and the response is an area of very active investigation. And there are elements that we now are beginning to understand about the individuals with a high circulating tumor DNA fraction or often have a lower PSMA PET uptake and a higher FDG PET uptake. You know, there are actually, 5 different types of PET scans that we could talk about. But the PSMA PET and the FDG PET give some alternative information. It's complex and we need to study it more. But anyway, provocative questions. I'm sorry, Mike.
Sorry, I didn't mean to.
No, but I
interrupt
wanted to elaborate on that. It's a very good question. It's an area of active investigation.
So just real quick about investigations and trials. In your opinion today, what is the best source for patients to find appropriate trials?
For the theranostics trial,
Yeah.
the X-Cancer site is the best that I've seen. I'm trying to remember the name of it. I think it's Theranostic Trials
Yeah,
.com or .org.
Yeah.
Theranostic trials, and it's part of the X-Cancer kind of suite of trials. That's the single best one. The NCI is also good, but it's a bit more complex. Talking to your physician is always good, but they often know about the trials where they are.
Right.
But Google can get you moving.
Thank you.
Yeah.
Okay, I think we might have time for, maybe one more question, and then Mike, do you want to introduce our next speaker?
Sean Lucas got it.
Okay.
Just one more. So actually the use of FDG was usually not recommended for prostate cancer, but it looked like in the case that you're describing now with Pluvicto, we do need an FDG along with a PET scan, a PSMA scan?
Again, another very good question. So if you go to the Australian trials, they're typically using 2 PETs for the selection. The problem in America is even though you can get an FDG PET, and you might be able to certainly get a PSMA PET, if you try to get both, you're probably going to run into insurance troubles. In the design of the trials, we very specifically decided not to do 2 PET scans as a requirement because we were concerned about the reimbursement when we got to commercial activities would prevent patients from getting the 2 PET scans, and it's still true. So I can order 1 PET scan on you, and I might be able to order another one in 6 months, but if I try to do 2 PET scans and get them within a week, your insurance company is going to say, no way, we're not paying. So if I tell somebody I need 2 PET scans to evaluate you for Pluvicto, but I can only get 1 paid for, we've ended up in a conundrum. So again, in Australia, this is not a restriction. More PET scans, more better. Let's get an FDG PET. Let's get an Axeman PET. Let's get a PSMA PET. Let's get a choline PET. Let's get 4 scans, It'll be fun. But in the United States, it just doesn't work that way.
Thank you.
Okay, any others?
Just a quick thank you for Dr., one more question? No, 1 minute. Okay.
Oh, 1 minute.
Can we just thank Dr. Sartor for spending his time? Thank you.